Tourette syndrome, created by Emily McMichael, Bailey DeShutter, and Donna Minsky, presented for Social Work 8115, DSM in Clinical Practice. This section was created by Donna Minsky. Overview and history. Tourette's disorder falls under the neurodevelopmental disorders in the DSM-5. Within the categories listed, Tourette's is found with other motor disorders under the tic disorder subsection. It is characterized by sudden, rapid, recurrent, non-rhythmic, stereotyped motor movements and vocalizations. Tourette's disorder is found with other tic disorders that are characterized by their respective specifiers and features. Tourette's disorder has always been included in the DSM historically, although the language used to specify the disorder has changed over time along with certain features. Previously, Tourette's was listed among other obsessive behaviors and disorders, but can now be found arranged with other neurodevelopmental disorders rather than those more associated with mental health. The first DSM was published in 1951 and listed the criteria for Tourette's among diagnostic criterion for echolalia, interjectional speech, habit spasms, spasm nutans, or nodding of the head, and tics, irregular muscle contractions. It was also listed with other obsessive behaviors such as neurotic excoriations or skin picking, and trichotillomania, which is the obsession and compulsion to pull out one's hair. In 1968, the release of the second edition of the DSM was published, but it did not list tics exclusively anywhere else. In 1980, the DSM-3 was published, and with it came the diagnostic criteria for Tourette's disorder that we are most familiar with. The diagnostic criteria included age of onset between 2 and 15 years of age, a description of symptoms with variations in intensity that have lasted for more than 1 year. In 1987, the DSM-3 had a text revision that included language to identify whether symptoms were intermittent or if they happened together or separately. 1984, the DSM-4 was published, and Tourette's disorder listed the same specifiers as previous editions. However, more specific language was used to clarify the duration of the symptomatic behaviors. They included that through the year of consecutive presence of symptoms, there was never a tic-free period lasting longer than 3 months, meaning the symptoms came and went, but were never absent for longer than 3 months at a time. Within this edition and the text revision of 2000, the age of onset was changed from 2 to 15 to any time before the age of 18. The DSM-5 is the most recent edition that has been published. It was published in 2013. It lists Tourette's among neurodevelopmental disorders alongside intellectual disabilities, communication disorders, autistic spectrum disorders, ADHD, and ADHD. It's included in the motor disorders and is listed as a tic disorder. The diagnostic criteria for Tourette's is listed here. It's persistent, chronic, motor or vocal tic. Both tics present at some point, but do not always occur together. It may come and go, but it has been persistent for more than 1 year. The age of onset was before the age of 18, and it's not attributed to any other factors, such as the effects from substances or any other medical conditions. The other 2 tic disorders listed with Tourette's are persistent and provisional tic disorder. Persistent tic disorder has only one single specifier present, with vocal but no motor, or with motor but no vocal, never both at the same time. It comes and goes just like Tourette's, and it has not been attributed to any other medical condition or effect from substances, and has never met the criteria for Tourette's. Provisional is similar. It can have a single or a multiple presentation, motor and vocal tics, but it only happens for less than 1 year, and it too has not been attributed to any other medical condition or effect from substance, and has never met the criteria for Tourette's.
So this slide was done by Emily McMichael, and it is for critical thinking. While there is no specific test that can be given to diagnose Tourette's, an accurate diagnosis can be made based off of signs and symptoms. While some signs may mimic other conditions, tics are typically obvious and can lead to an accurate diagnosis. For example, while squinting the eyes is a common tic, it can also be a symptom of vision issues, so these things can sometimes get confused.
Here is listed the co-occurring disorders that can accompany Tourette's disorder. As you can see on the infographic image of an iceberg, Tourette's motor and vocal tics are usually on the surface. Those are the things we notice first. And below, there are many other conditions and issues the individual is experiencing. To the right is a graphic of children aged 6 to 17 years old. The red line represents those diagnosed with Tourette's and also a co-occurring disorder, and the blue line represents just a singular disorder. As you can see, those who have a co-occurring disorder, the more common disorders known to children, you see those with Tourette's have a far more occurrence of two comorbid kind of issues happening at the same time. In the upper right-hand corner is a graphic that depicts the overlapping nature of these childhood disorders: sleep problems, school problems, peer and social problems. They all kind of overlap each other and create complexities within the diagnosis.
So for our case example, I chose a video of a mother speaking about her 11-year-old daughter who has a battle with Tourette syndrome, and she explains very well kind of what happened when she started realizing signs. So I thought that this would be a good example on how to recognize Tourette's. So this slide Bailey and I worked on together. It's possible implications of Tourette syndrome. Some common difficulties young people with Tourette's may face include the lack of support from school staff, being bullied due to tics, trouble concentrating in class.
And a loss of opportunities. There is actually a user on the social media app TikTok that self-reported that she went to school to be a kindergarten teacher, but had to stop when her Tourette's caused her to swear and use inappropriate language while she was student teaching around the students. And the positive implications are an enhanced tendency to cognitively control themselves. There was actually a research study done on the mechanism that helps children suppress tics, and they found the constant struggle led to a higher ability of the brain to process information and a higher level of adaptation. Verbal strength. There was also a study that showed children with Tourette's had strengths in assembling sounds and processing general grammar. They also tend to be more creative, and they are often more empathetic, energetic, and resilient. So I did this slide, Bailey did the slide for evidence-based intervention. The one that came up the most during my research was habit reversal training, or HRT. There are 3 central components to HRT. The first being awareness training, which is a focus on creating and building awareness to tics happening, what happens during the tic, and recognizing the urge before a tic. Competing response training is creating a behavior that's physically incompatible with a tic to implement when the person with Tourette's is able to recognize the urge before a tic. And social support is where a social support person reinforces the competing response. They're trained to help with awareness training and competing responses. Clients that received HRT experienced reduced tic frequency up to 18 months after their initial treatment phase. And the graphic here is just an example of a competing response. And I also listed some other examples, like instead of pulling hair, maybe balling your hand into a fist, or rubbing your earlobe, licking your lips instead of picking your lips, and things like that. Another evidence-based intervention is medications. They can be used to reduce the severity or frequency of some of the more problematic tics. It can take time to find medication that works best, as it varies from person to person. Some medications that were proven to reduce the severity of tics were Haldol, Pimozide, Risperdal, Prolixin, Catapres or clonidine, and guanfacine, which is 10x. And these are actually all antipsychotic medications. And then the less studied medications are Klonopin, which is actually an anxiety medication, Inversine, topiramate, which is typically used for seizure control, and baclofen, which is a muscle relaxer. And these are the references that we used for our presentation.